So before we get started, for those of you who have heard me speak before, I love this slide because it is a nice way to disclose that I have nothing to hide. Unlike this physician, I am not sponsored by any medications or products. Unlike some of the talks that you may have heard or may hear later, this is not going to be something that is very overly scientific. This is going to be very clinically oriented. And the problem is chest radiology encompasses so many different diseases, so many different modalities, that in order for you to really get a good feel for it, rather than me sitting up here and scrolling through one CT, we're going to really do kind of an art history overview and just fly through a ton of images so that you can hopefully get a good exposure, at least, to some of the terms that are thrown around: bronchiectasis, ground glass opacities, et cetera. As an overview, these are the two main modalities that we're going to focus on: chest X-ray and CT. I know on the program it said MRI. You don't want me looking at an MRI. I wouldn't know what I was looking at. We don't use that for chest medicine. They use it in cardiology, but they don't use it in pulmonary medicine. Orthopedics, yes, not lungs. So chest X-ray and CT really are the main focus. We're going to get into possibly at the end just some virtual bronchoscopy, maybe a snippet of seeing what a superdimension, the electromagnetic navigation bronchoscopy, how we use that as a modality, VQ scan, ultrasound. I'll show you just some quick images just so you're familiar with what we look at on a regular basis. But I think these are the two that you have to understand and we've got to go through and focus on. So for chest X-ray, one of the biggest problems that people do is the chest X-ray is thrown up and they immediately focus on something sitting inside the lung tissue. That's the absolute wrong way to approach an X-ray. You've got to make sure and approach it systematically so that you don't miss anything. It's no different than any of you who round in the ICU and you're taught to do things by organ system. The purpose for that is so that you never miss anything. It becomes boring, it becomes rote, but that really is important to not make mistakes. So when I look at a chest X-ray, this is the order that I usually go through. First thing I want to do is see if there's any foreign bodies there. And I don't mean that they swallowed something. I mean, did we put something in there? Endotracheal tube, central line, pacemaker, et cetera. Then I focus on the trachea down into the bronchi. I look at the great vessels, run down the heart borders, because that can give clues as to where something might be in the lung that's abnormal. The costophrenic angles of the diaphragm, look for fluid in the fissure, run up the pleura, go to the apices, then I look at the lungs. So there's a lot of stuff that goes on before I ever focus on the lung tissue. This is all in your slides, and any of these pictures you guys have access to. Hopefully, if they haven't been printed out, you're more than welcome to them. I've given it to the crew. This is just to give you some basic idea, reference of different parts of the chest that you're going to be focused on. But again, trachea down into the main bronchi. This crowded area here, which Dr. Safdar will probably focus a little bit more on, is where you see the pulmonary artery outflow tract. Right here, a little bit more hidden on that side. The heart borders are relevant because they correspond to different lobes of the lung. Namely, the right middle lobe is going to be on this side. This over here is going to be lingula. And then down along the diaphragm, this corresponds to different segments of the lower lobe. So if I see something sitting here, I know it's in the anterior segment of the lower lobe. Over here, posterior, because it always goes ALP. ALP. So again, these are just things that you kind of pick up, but it's important to have a system. That's the point of this slide. On the lateral, same thing. It's not quite as intense in terms of going through, because really the main area you're focusing in on the lateral are the diaphragms and then this space retrocardiac. Because on the frontal view, you may miss something behind the heart, but if you see an abnormality here, that'll jump out much more clearly. I put this slide up because it's one of the first things I learned in medical school, and I thought it was brilliant because it really demystifies a lot of what we look at radiologically in terms of plain X-rays, because it's really hard. When you see people early on in their training, they'll see an abnormality on the film, and they'll try to start giving you diseases that might cause it or bugs that might cause it. You always want to break it back down to something more simple. So when you see a white shadow on an X-ray, generally speaking, it's one of these 4 processes. And so you can usually figure that out fairly easily clinically or with other clues on the film. So atelectasis, pleural effusion, consolidation, meaning generally pneumonia, infiltrate, some kind of a dense process of inflammation, and then tumors, whether it's malignant or benign. So this just emphasizes 3 of those points. Atelectasis, where there's been collapse of lung tissue, and so you get that white shadow. Consolidation, which is a pneumonia. Again, you get dense infiltrate, which causes that haziness or clouding. If there's a tumor, whether it's a nodule or mass, and we'll talk about the distinction later. And then if there were pleural fluid here, rather than these interstitial markings, that would be the other main reason why you might see it. So before you start throwing out, maybe it's pneumonia, maybe it's cancer, try to think of it in those 4 generally descriptive terms. I think it's much more helpful. So let's focus on atelectasis, because this is excruciatingly common in hospitalized patients. I like to use these diagrams or schematics before I show you an image, because I think it helps to at least conceptualize what it should be ideally, and then see how close the real-life version comes to it. So in this situation, the right upper lobe is collapsed. Therefore, the lung is being pulled up somewhat. The diaphragm itself pulls up. The trachea usually deviates back towards the patient. That's not going to be the case when they have an endotracheal tube sitting in place. But those are little clues. So if you were looking at this and you saw white up here, you saw the trachea coming towards you, the diaphragm was higher, even though theoretically that could be a pleural effusion that's loculated up top, unlikely. It's much more consistent with an atelectasis picture. So here's an example of what it looks like in real life. So again, you have that clear loss of aerated lung tissue, and the diaphragm is higher on this side pretty substantially compared to the other side. Middle lobe collapse. Again, I told you when you run those heart borders as you're looking at the plain X-ray, if there's cloudiness on this heart border, that is going to be representative of a middle lobe pathology. On the lateral, it looks a lot different. You're going to have this wedge-shaped area. But this is what it looks like, where again, normally you should see a nice sharp line. And it's not usually huge. For those of you who work in cardiology, you may see big ones over to the side with big right atrial enlargement. But the reality is you should see a clear border, which here you've lost it. Left upper lobe collapse. Mirror image of the other side to an extent. Again, tracheal deviation. A good thing to keep in mind when you see the trachea move one way versus the other, if it's being pushed, it's going to move away. If it's collapsed, it's pulled towards. So again, it just shows a degree of haziness, a degree of whiteout. There's no way you can look at this plain film and say there isn't a tumor there. You can't say that there isn't loculated pleural effusion. But the likelihood and the most consistent other findings, because you're not seeing other things on the film that would suggest alternate diagnoses, is probably atelectasis, whether it's a mucus plug, aspirated foreign body, or tumor. Again, anything that causes a blockage of the airway, occludes an airway, everything beyond it is going to collapse. So, simple physiology on this. So for those of you who can't read this, our preliminary tests have come up inconclusive. Perhaps a series of x-rays can pinpoint just what's wrong with you. And clearly she has something very, very wrong with her. So in terms of diseases, again, I'm going to kind of fly through these. We're not trying to go into all the nuances of the clinical management of problem A, B, or C. but I want you to really get a feel for what things look like with the different modes of radiology. And we'll go back through these again with CT scan to get that view and that side of things. So starting off with pneumonia. Remember, there's basic clinical types. You'll often hear these terms thrown around: community-acquired pneumonia, hospital-acquired pneumonia, nosocomial pneumonia, vent-associated pneumonia, and even HCAP, the hospital community-acquired pneumonia, for people that are regularly hospitalized, getting chemotherapy, living in a nursing home, et cetera. But really, from an X-ray vantage, we're more interested in looking at pattern types. So there's either kind of standard routine lobar pneumonia, atypical pneumonia, which is referring to the bugs and how they gram stain rather than their appearance on X-ray. A lot of people make that mistake. They assume that atypical pneumonia with Mycoplasma or chlamydia is how it looks on the film. No, it's how it looks on the gram stain. But aspiration pneumonia will have its own kind of pattern, and then other opportunistic infections like pneumocystis. So here's a classic lobar pneumonia. And I'm not sure in the back if you can fully appreciate it, but do you see these black lines here? It comes up way better on the CT scan, like everything does. But this is classic air bronchograms. So when you hear that term, that's what they're talking about. It's literally just highlighting the bronchial tubes within a sea of dense consolidation of the lung parenchyma. Again, here's a classic walking pneumonia, kid at college, military recruit. This is going to be a bug that's not that bad for most people, again, assuming you're not immunosuppressed and other major comorbidities. But this is what it may look like, just kind of a non-specific haziness in a variety of distribution. It can be upper lobe, lower lobe, et cetera. Aspiration pneumonia. Now again, we see this all the time in the hospital and emergency rooms when people come in after being inebriated. The reality is the classic description of where aspiration pneumonia is going to happen is on the right side, because anyone who's ever been in a bronch or seen the lung anatomy, the right main stem bronchus is a nice straight shot down. The left main stem bronchus is a much sharper angle for material to go into. Now, if I got drunk, vomited, and was laying with my left side down, obviously gravity is going to change the course of material and where it may go. But for most people, when they are impaired mentally, for whatever reason, they're usually going to be laying back, and if they vomit, it kind of goes down into the most dependent part of the lung. And that is generally the posterior segment of the right upper lobe and the superior segment of the right lower lobe. Now, you see how well you can see the right heart border here? It never goes in the right middle lobe unless you puke and you lay face down, because the takeoff for the right middle lobe is literally straight ahead. So it just doesn't do that when you're laying on your back. So when people have an infiltrate in the right middle lobe, don't assume it's aspiration pneumonia. That's extremely unlikely. It's more commonly going to be an atypical infection like MAC, the mycobacteria, Lady Windermere syndrome. So again, this is a classic aspiration pneumonia pattern. Keep this in mind, because those two spots, superior segment of the right lower lobe and posterior of the right upper lobe, are also the two most common spots that primary TB occurs. So, Bentab ER, homeless dude comes in, altered mental status, that, respiratory isolation until further notice. You don't know. Pneumocystis jirovecii, which when I went through training was Pneumocystis carinii. So this is the pneumonia that, again, commonly seen in patients who are immunosuppressed. It was the classic pneumonia when I was in medical school that all the AIDS patients were coming in dying from. This is an extreme example on chest x-ray of what it may look like. It can look almost normal, and it can look up to this bad. Again, it has just kind of a diffuse involvement. But if you have an HIV patient, hasn't been on their meds, desaturates walking from here to 3 feet away, has this x-ray, good chance that it's going to end up being PJP. Pleural effusions. I didn't appreciate this as much when I was in training as I do in practice, because pleural effusions really do come in 2 basic flavors. There's free-flowing, which means it's easy to deal with. You just drain it, get a thoracentesis, I'll do it, you guys do it, whoever, it's not hard. Loculated pleural effusions is a whole other animal. And the problem is when you start dealing with this and you're monkeying around with just trying to do thoracenteses, these people generally are going to need something surgical done. And if you wait around and dilly-dally, it becomes a much harder process to address and to treat. So understanding when you look at an x-ray, if it's going to be a simple straight-ahead process, or, uh-oh, I'm going to have to bump this up to somebody to deal with it surgically, it's really important to know. So this is obviously a huge area of white out. Could it be atelectasis? Yes. Could it be a rip-roaring consolidative process like a pneumonia? Yes. Could there be tumor in there or causing this whole thing? Yes. Could it be pleural effusion? Yes. So when you know that this patient has liver disease and they're volume overloaded and they get drained every 3 days, you know what this is. This right here may be a small rim. Do you see that single line? That may be some atelectasis, but the rest of this you really have to just assume is fluid. This one, even less obvious, unless you get the clinical story. And this is the one where it really is almost impossible to hurt them by doing a thoracentesis. Their lung has been pushed down to a little nub. And so even though we still use ultrasound, we probably don't need to. You can just throw a dart from across the room and that's going to work. This is where it gets tricky. So when you look at this, if this line came down and then went to here, fine, that would be fantastic. But where in nature do you see fluid do that? That obviously indicates there's some inflammatory component and it's been walled off or partitioned into segments. You're never going to fix this situation by simply a catheter to drain. Now, you may fix it with a chest tube, you may fix it with VATS, you may fix it with decortication, but it's not going to be just a simple routine thing. I wouldn't even try. I would just call my friendly thoracic surgeon and say, come on up and get a tube in them at least. Not sure if this is true or not. In terms of lung masses, obviously big consolidative soft tissue tumors within the chest can be malignant, and that's our primary concern most of the time. It can also be some benign processes. So I want to make sure you guys see what this looks like. But ultimately, when you've got a big enough mass and you're not sure what's going on, PET scan would be wonderful to order, and I think I've got a picture of a PET scan at the end. You can't do it inpatient, so that's an outpatient conversation. But that may indicate whether you need to aggressively go after it or not. Most of the time, we want tissue. So this is something, if you look at a plain film, you're going to see this here, and the radiologists are going to say there's a opacity in the right mid-lung, not sure what it is, could be A, B, C, D, clinical correlation advised. The reality is, it's easy when we have this wonderful little cheat sheet here telling us what it is, that it's actually something sitting with the fissure on top of it. This could very well be fluid in the fissure. It usually has a slightly different appearance, but the bottom line is this would be something you'd have to get a CT scan to get a better view on. We're going to go more into the nodules and the masses on CT because that's really where we look at them. For nodules, the official definition is less than 3 millimeters. If masses were more than 5 and nodules are less than 3, what's 3 to 5? We're not sure. I mean, that really, it's kind of a gray area, and most people will treat them as nodules more than they will masses. But the bottom line is, once you're getting into that size, you're going to be getting tissue. You guys probably have seen reports on CTs as the generation of scanners have gotten better and better, and people are getting CT scans before every ablation procedure for AFib. We're getting these little ditzels picked up all the time, the 3 millimeter, 4 millimeter nodules. And the reality is that's too small to really do anything about. Even for our smokers that are 2 packs a day for 40 years, we're probably not going to rush to cut those out just yet. We usually follow them closely. If they demonstrate a change in size and we ultimately can show any kind of increased activity with PET, then we'll be aggressive. But you have to remember, all comers, smokers included, 60% of the time when you see a solitary pulmonary nodule, it's benign. These are usually granulomas. Everyone in this room, whether you're from Houston or not, you've been here long enough now that you've been exposed probably to histoplasmosis. It's a fungus that's everywhere. And the reality is, many people in this room, if I scanned you, would have a little granuloma that doesn't mean anything and never will. So understand, when you see a nodule, don't immediately tell your patient, oh my God, it's probably cancer, we're going to send you to the lung doctor. It's probably not. Here's an example of a nodule, which is probably a lymph node, which is calcified. You can see it's a pretty good-looking circle there. Now, you can't make too many determinations on a plain chest X-ray other than, again, if this is calcified, which means it's kind of the same intensity and density as the bone, then you can be fairly calm that it's going to be a benign process. The fact that it's nice and circular, we'll go into more detail with CT, but that's a good sign. This is not a good sign. All these little smudges that you see everywhere, bang, 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 bang. This is just something that has spread from elsewhere that is obviously hematogenously spread. You think about the blood flow into the lung, and it just carried cancer everywhere. This is not going to be a good outcome. This, on the other hand, looks like tiny, tiny little millet seeds. This is a pattern of tuberculosis that's very unique. I personally have never seen it. I've read about it. It's on exams, but I've never seen one clinically. Now, I think this takes us into pneumothorax. Yes. Okay. So obviously, if that guy got stabbed like that, he's probably going to have a pneumothorax. The thing that comes up all the time, especially on ICU patients, is the technologist is going to come in the morning, jam that canister underneath their back. Needless to say, here in Texas, we have a lot of folks who are overweight. And so it's not uncommon for skin to get pushed around and for folds to sometimes be highlighted on imaging. So it's really important for someone who clinically is doing beautifully, no alarms are going off, no blood pressure problems, they've been fine on the same settings forever. If suddenly you're getting an urgent call that they have a pneumothorax, I'd be triple checking before rushing in to do anything. So when we say follow pleura to pleura, we mean really you want to find it right against the edge here and follow it back to wherever the edge would be over here. So this is an example of a true pneumothorax. Now, that's not an enormous one. That's pretty small. So this patient is probably going to be managed just with oxygen. If they're on a ventilator, slightly different issue because you're pumping in positive pressure. That may require something more invasive. Here's a situation of somebody who had a pneumothorax, and it's pushed down the image so much so that you end up with what's called the double diaphragm sign. So here's a diaphragm right here, and here's a diaphragm, and that's because of air forcing down and being in a place it shouldn't be. It's hard to see, I think, for you guys, but the lung is pushed down to right there. So all that black is truly air that's not doing anything good. It's where it shouldn't be. This is another thing that we see not uncommonly in the ICU, this deep sulcus sign. So again, just like with any other specialty, orthopedics, whatnot, in the chest, in terms of lungs, God gave us two so we can compare one side to the other. And the reality is, you can tell that this side looks okay, but this side, there's something dramatically different going on. And that's because air has tracked down and is trying to escape from the chest. You also see over here, do you see this stuff? That's sub-Q emphysema. How many of you have ever felt sub-Q emphysema? A lot. So for those of you who haven't, if you've ever stepped on fresh snow and it kind of breaks underneath you, that's what it feels like. It's got that give. It's a very interesting feel. If you ever have the chance to feel it, you only need to do it once. You'll never forget it. I put this x-ray here because this is a huge pet peeve of mine. As someone who takes care of a lot of COPD patients, radiologists will look at this film and immediately say, COPD. Now, in fairness, I agree. Those lungs appear hyperinflated. But I don't know that that isn't just somebody who is 7 foot tall and really thin. We see that. So you can say, and I never have a problem if you say your x-ray shows hyperinflation, there's a question that that might be some COPD. You need to have it tested. But you cannot say that someone has COPD without doing lung function tests. It's the only way to make the diagnosis. Now, I do a lot with COPD, and I put this here. I'm going to show you some other pictures and images. Lung volume reduction coils. This is a research project that I've been involved in at St. Luke's and here at Methodist. It uses an alloy of nickel and titanium that's a memory-shaped metal. So when you pull this thing straight and let it go, it folds back into this shape. We implant them in the lungs, and the purpose of it is to reduce the overall lung volume, but also to reestablish elastic recoil and structure of emphysematous lung that's been damaged. The FDA is looking into approving it. It's already standard of care in Europe. And so hopefully, in the next 12 months, we will have a green light. This is an example. This is the first patient that we ever did. And this shows the coils in place after both lungs have been done, separated by 4 months, but this was once everything was finalized. It's important not for you guys to know much about this other than to look at this and not go, is this guy a terrorist? What's this going on? And we give them cards when they go to the airport specifically so they don't get harassed. This shows, I'm going to show you a series of images that demonstrate what it looks like when we put them in place. And this is the bronchoscope. This is actually stolen from the company website. This is done through a rigid bronch, which we don't need to, and in this country we don't use for this purpose. And then this is a catheter that we use to kind of go in and measure the airway to see what size coil we can put in. So when we put them in, we're going into the random airways, wherever we can find an airway in the upper lobe or lower lobe, whichever one we've been told to do. And so that's what they look like under fluoroscopy in the bronch suite. And again, the purpose of that is to reduce the overall volume of that hyperinflated lung and then reestablish recoil. Pulmonary edema. Again, a schematic showing the ideal of what happens when the things go badly cardiac-wise. You've got the increased pulmonary vasculature centrally in a bat wing appearance. You have increased cephalization of vessels, curly B lines, pleural fluid both sides, cardiomegaly, yes or no, depending if it's systolic or diastolic. And so that's a classic film that everybody in here, if you're in clinical medicine, has seen a million times. This is a positive Methodist sign or a positive St. Luke sign. ARDS can look almost identical. Usually they'll have a tube down their throat, but the reality is ARDS is pulmonary edema as well. It's just non-cardiogenic pulmonary edema. You usually won't get the cephalization of vessels, but you will get that bat wing appearance, just haziness that looks like something bad has happened. IPF is a really tricky one. And all I would tell you is when you're listening to patients who are not obviously volume overloaded, but you hear crackling, and it's that dry crackling like Velcro opening and closing, and you look at an X-ray and you see just kind of some non-specific increased markings at the base. It looks almost like cotton that's been pulled apart. That can be ILD, IPF, whatever you want to call, it, because it may end up being not IPF itself, but one of the other interstitial lung diseases. But that's bad. That's not fluid. This is definitely very different. And if you look here, you don't see an ounce of pleural effusion either side, but you see a lot of haziness down here. If you had enough pulmonary edema to give that pattern, you're going to have fluid in the pleural spaces as well. So that's something as a trigger for you to be thinking. We talked about primary TB, and again, this right here is going to be the posterior segment of the right upper lobe. Here's the fissure that's demonstrating it. Could it be aspiration pneumonia? Sure. Could it be another lobar pneumonia? Yes. But again, if this was somebody who came into the emergency room wearing a Houston Chronicle hat, anybody know that's a risk factor for TB? I'm not kidding. All the guys who sell the Houston Chronicle on the side of the road, they all live in a community house together. Every one of them has TB. So be careful buying your paper at the stoplight. This is what reactivation TB might look like. Again, it's just white, so you can't really make that diagnosis in and of itself. But reactivation TB usually impacts the upper part, the apices of the lungs, more than it does the middle section of the lung. And then if you see this, a cavity, see that rim? That may very well be old, burned out TB. That could also be cancer. So you have to understand the context, but that's what a cavitary TB pocket would look like. In terms of mediastinal pathology, I'm going to do this quickly because it really doesn't lend itself well for regular chest X-ray. But when you see a bunch of stuff in the central part of the chest, you're worried about what's causing the lymph nodes to be big. So the usual differential diagnosis. Is it cancer, lymphoma, sarcoid, et cetera? There are some calcified nodules, lymph nodes in the central part of the chest. Again, could be from an old granulomatous process. So talking about the hand of man. When we look at X-rays and when we get a daily X-ray on somebody in the intensive care unit, the main reason we're doing it is this. We want to make sure that the tip of the endotracheal tube hasn't migrated with them turning and the field trip they took downstairs for CT, et cetera. You've got to make sure that isn't about to fall out and create a bad situation. You also want to make sure that lines are in the correct place. Sorry, I'm off angle a little bit. Going to there. So that shows the endotracheal tube for those of you who couldn't see it from the back. That's the carina. Now, when you try to figure out if it's in decent position, there's a number of ways to look at it. A lot of people will say you want to be 3 to 5 centimeters above the carina. That's great if you can see the carina. Some say it needs to be between the clavicles. That's kind of the bare minimum. What I usually say, and on this one it's not as easy to see, but generally the aortic arch is the best landmark, which is pretty consistent regardless of position, assuming they don't have a huge aneurysm. That's the best level to keep it at, the level of the aortic arch. And then that's the central line tip, which is right at the junction of the superior vena cava into the right atrium. Now, this is something I always point out to our fellows because few of them ever know how to make the distinction between a pacemaker and a defibrillator. And I can tell you in the office, patients never remember which one they have. And when they give me the little card that they got from Boston Scientific or whoever, I don't know what it's ABD, ZZ, it's saying a bunch of things that don't mean anything to me. So I look at the plain X-ray, And a pacemaker is going to have these normal thin-looking leads, whereas a defibrillator, this right here and that right there are the paddles. That's all you need to know in terms of distinguishing between those two. For pulmonary embolism, again, this is somewhat academic. I'm not going to belabor this. There are a number of findings that are classic and are written in the literature for pulmonary embolus on plain chest x-ray. In today's world, where anyone who shows up to the emergency room and says, my left toe hurts, they get a CT angio-PE protocol, right? We never look at chest x-rays for PE anymore. So these are things that are on your handout that may occasionally be asked on an exam. The reality is the most common sign or the most common finding for patients with PE on radiograph is atelectasis. Not normal, atelectasis. That's the most common. And it's usually just going to be some subtle little bit of atelectasis right here that, again, it wouldn't tip you off clinically in and of itself. All right, so we have focused on the ancient way of looking at things. Now let's move ahead and be a little more modern. So with chest CT, there are a lot of different planes, or for any CT in the body, a lot of different planes that can be used. We usually look at things in the transverse plane. And it's actually interesting. When I was in medical school, I went to Georgetown, and up the street at Johns Hopkins, they were putting in place a program where they didn't do gross anatomy in the cadaver lab the way we did. They learned anatomy off CT scan. If they ultimately went into surgery, then they went and did a lab later. I thought it probably would have been more helpful than what we did, because I wasn't going into surgery and that was just a rite of passage. But this is really, when I look at anatomy, this is how I visualize it in today's world. So this is going to be a basic view of the lung, and then it's oriented this way for you. As I always point out to people, when you're getting your orientation, we're looking from the patient's feet up through their body towards their head. This is the front of their body, back of their body, right side, left side. When you're looking at the CT scan, you see all these little white dots? These are blood vessels. They just happen to be blood vessels pointing straight at you that are cut cross-section. Whereas, this is a blood vessel that's tangential, so you just see it better. I always start by telling people that because inevitably I'm looking at the films with them for a nodule or a mass. They see a couple of these and they're freaking out before I even get to the little 3mm thing that they came for. When you look at a chest CT, it's very important to know which window to pull up so that you can really pay attention to the pathology that you're interested in. So if you're looking at a lung nodule or bronchiectasis, you're going to want to see the lung windows. When you're looking at something in the central part of the chest, mediastinal structures, or you're looking at blood vessels, you're probably going to want to look at the mediastinal cuts. Pleural effusion is seen much better on the mediastinal windows. But you need to be able to look at both, and you should look at both on everyone. So don't just immediately go to one quick view and that's it. I put this slide here not to teach you anatomy, but to make a couple of points. The first one is the trachea sits in front of the esophagus, and even though the esophagus can definitely enlarge to accommodate steak or whatever else we're swallowing, it is generally a tiny, tiny little pinhole compared to what the trachea looks like. So that's just an important reference for you to have. And if this thing starts looking huge, they may have some other process at play, achalasia or whatnot. The other thing is there's a lot of crowding of structures in this central part. I think Dr. Finkelstein will talk a little bit later about what tests to order and when. But keeping in mind with a CT scan, if you're worried about teasing out what's going on in the mediastinum, lymph node versus blood vessel versus airway versus other, you've got to have contrast. If you're looking at a pneumonia out in the lung tissue, you don't need contrast. If you're looking at pleural fluid, no need for contrast. If you're following up a lung nodule, no need for contrast. First image off of an abnormal chest x-ray and you're worried about a possible cancer or nodule or growth, you probably do need contrast. So you have to understand what it is you're looking at and trying to tease out to determine yay or nay on contrast. Because again, people have kidney dysfunction, it means they have to get a creatinine first, it's harder for them to handle, and it's just, if it's not needed, don't put them through it. Everybody has heard the term ground glass opacities, but I suspect most of you don't really know what it means. So if you think about ground glass, think about if you've ever been to the beach and you found a bottle and the sand has worn it down at the end. And if you were to pick it up and look through it, you could maybe make out structures behind it, but it doesn't have real clarity. That's all they're saying here. So if there's ground glass opacity, it's going to be a degree of haziness, which is usually fluid, number 1, 2, 3, 4, 5, or inflammation, but you can still make out the structures behind it, as opposed to consolidation, where it would just be a big chunk of white and you couldn't see anything behind it. So this ground glass opacity, everybody reads it and freaks out on a CT scan. It usually just means they're a little bit fluid overloaded. So don't build it up to be anything more dramatic. That's all it is. So in terms of the diseases, again, we're going to kind of run through these just to make sure that we touch on the images and the views and you know what it is we're looking at. PE on CT scan. Now, this is a saddle embolus. Do you see this gray right here? That should not be there at all. That should just be a big white trunk, both sides. So that is, as we would say in Boston, wicked big. Not massive. Massive is a definition that requires shock or hypotension. But that is a big clot, and depending on their underlying cardiopulmonary reserve, it may be hemodynamically significant, it may not be. Here's another view of a clot sitting inside of the airway, inside the vessel. So again, you should have this nice big river of contrast and blood, but you have this blockage. Here's some other examples. There's one, there's one. And remember, even though they may only comment on the report that there's a clot here, almost everyone, when they shower pulmonary emboli, shower at both sides. It's very rarely just going to be one side. But really, you're looking at what's the clinical significance. How hypoxic are they, right-sided heart strain, blood pressure, et cetera. This is a different version of emboli. And so you can appreciate you have nodules in different sizes, so different ages, and different degrees of cavitation. You know for a fact this came from an endovascular source. Endocarditis, an indwelling central line that's got a infection on it. So this is septic emboli. And again, in terms of management, whether you're just going to use antibiotics or whether you're going to also use some blood thinners, that's open for conversation. Again, in terms of the lung nodules, this is where we can get into a lot more detail about what the nodule really looks like. And so patterns are important and the margins are important. When you have a nice smooth looking structure, it's probably benign. When it's spiculated and looks like a nasty asteroid, that's a bad thing. And when it's in between, it can go either way. Pattern, calcification is usually benign as long as it's uniform. When you have eccentric, one-sided calcification, that may be a little bit different. But generally speaking, 99.9% of the time when we see a calcified nodule within the chest, nothing to worry about, nothing further to do. So here's an example of a nice smooth circle. That would be something that would be more lobulated, and that's nasty looking. Again, benign patterns of calcification, nice diffuse calcium throughout. That would be something that might be a little bit odd. So there's a nodule, and the reality is that's just sitting in the middle of nowhere. These are the ones that are really hard because thankfully this one's big enough. You could probably do a PET scan and see if you need to chase after it right now, or you could wait and watch. It's not one that's easily going to be obtained by bronch, and it's not easily going to be obtained by CT-guided biopsy from the outside. Now, if this is someone young, smoked their head off, you get a positive PET scan, you're just going to send them to surgery and cut that lobe out. But when it's the 85-year-old grandma with minimal lung capacity, it puts you in a much tougher situation. This one is nice because it's up against the edge. That one's going to be easier to send to the radiologist for a CT-guided biopsy. Because remember, on that previous one, if you're going in along that track, you're going through all this normal lung. So the likelihood of getting a pneumothorax is 100%. It may not be clinically significant, again, depending on the person, but it's just a risk that you're generally not willing to take if it can be avoided. This one, the risk of pneumo is not 0, but it's substantially less. On this one, not sure what's going on over here. I'd have to scroll up and down more. It looks like that's just some collapsed lung, but whether that's diaphragm that's come up, I can't tell definitively. But over here, these are all nodules. So you could probably go in and do a bronchoscopy, and I'm sure you'd find something sitting in the airway, or just doing random bites, you might be able to pick up something. I wouldn't do random CT guided on this one. Kind of missing the point there. In terms of lung masses, again, the features for biopsy, obviously peripheral location is ideal if you're going to do CT guided, and I'm going to show you this thing called Bronchus Sign, which makes the yield from a standpoint of doing superdimension substantially higher. So first of all, if I saw this, if this person was sent to my office for abnormal lung mass, needs a bronch, I would send them right to radiology for a CT guided. It's going to be quicker, easier, faster, better yield for them than going through the drama and the waiting process from a bronch. This is a real close-up, but the point that it's trying to make is if you look, this is actually airway right to here into the nodule. So this is going to be a tiny little peripheral nodule. And rather than trying to find a needle in a haystack, we can do this thing called superdimension bronchoscopy. And I'll show you images right at the end, where we marry a computer kind of map to the CT scan, and it will direct us almost like a GPS. Go right, go left, go up, go down. And we can get to that basic vicinity, as opposed to if we did it old school, where we'd know it's in the upper lobe, we go into the upper lobe, and then just start blindly trying to find an airway that takes us there. The yield for doing it the old traditional way was about 30%. If we have this, the yield can be up to 80%. Super dimension bronchoscopy. It's electromagnetic navigation bronchoscopy. Super D is just the company name. It's easier to say. This right here is a term, rounded atelectasis. I don't know if anybody's ever heard this or seen it, but it's a mass that kind of has this tail, and it also has these little streaks that go along with it. This is usually from asbestos. It's not a tumor in terms of cancer, generally, but it's something that happens because of redundant tissue, redundant pleura, that kind of gets caught, and then it has that collapse, that atelectasis, that has a mass-like appearance. So if you saw a mass on chest x-ray and then found this, probably not going to be anything to worry about. Here's a cavitation, squamous cell cancer. Again, that certainly looks ugly to begin with. And as opposed to the septic emboli, where you saw showering everywhere, this is a single cavitary lesion. that would be cancer until proven otherwise. As opposed to these multiple cavitary lesions, could have been septic emboli gone bad, could be Wegener's granulomatosis, any other condition with cavitation and chronic inflammation. Reactivation apical TB obviously looks just cavitary, but we know where it happens. And here's a classic example of a fungus ball. So again, this is where a fungus like Aspergillus will set up residence in an old cavity left behind by pneumonia or TB or other. The treatment for this is not antifungal therapy. The treatment for this is cut it out, because you're not going to be able to fix this. If you gave an antifungal drug, it is not, there's no blood supply to get it there. It's just sitting in a hole by itself. It's completely protected. So you need to cut that out generally, because most of the time that fungus ball bangs into the wall and causes bleeding. And so that's what they'll come in complaining of. So don't try to put them on anything medication-wise. Mustache is a dead giveaway. So in terms of pneumonia, we talked about those air bronchograms. Here you go. That shows them with a little more clarity than what we saw on the regular chest x-ray. But again, lobar pneumonia, classic for, say, a streptococcal pneumonia. An atypical pneumonia, rhinovirus, human metapneumovirus, any of the other RPP positive entities that we see here. Pneumocystis jirovecii. Again, looks atypical, but when you look closer, it leaves behind all these little cystic type structures. So very involved, and clearly, when you look at it on CT, you can appreciate why their oxygen tanks from that interstitial involvement. In terms of bronchiectasis, this is in honor of Brian. Brian, where are you? So atypical mycobacterium, cystic fibrosis, ABPA are classic conditions where we will see this. It also happens commonly in COPD patients. And so we need to pay attention, because this can be something where chest clearance modalities may actually have a role in helping to keep these folks out of the hospital. Here's an example of a CF patient. And so when we talk about bronchiectasis, we're talking about airways that, rather than going from big to medium to small in tapering manner, because of chronic inflammation, they dilate. Once they dilate and the structure is altered, they never go back to normal. When that happens, the ability to clear mucus is less efficient. So you end up with lots of mucus problems, lots of plugging from mucus, lots of infections because of that airway getting gunked up. So these are all bronchiectatic segments. It should look like this. It shouldn't ever look like that far out, that peripherally. And so CF is the most classic example. ABPA is a situation where, again, it's that Aspergillus, and this is more kind of patients will come in with asthma that is just refractory to traditional treatment. They have this central bronchiectasis. Their airways just appear very pronounced and dilated, more than they should be in the central part of the chest. Again, this takes me to pneumothorax. I hope not. But this is an example of pneumothorax on chest CT. Again, on X-ray, you're trying to tease out, does that line go to the pleura? Is that real or not? Here, there's no debate. You could show this to a grade school kid, and they're going to go, why is it black there? So this demonstrates a classic pneumothorax. I put this here simply to emphasize, when a pneumothorax occurs, not only can the air get into that pleural space, but it can actually get out into the mediastinum as well. And so this is what it would look like with pneumomediastinum, where again, all the structures get profoundly highlighted because of air where it shouldn't be. And then this is all that sub-Q air out in the soft tissue. Pleural effusions. if you see this on CT scan, this right here, this gray, and this gray on the mediastinal windows are classic pleural effusions. This right here is the collapsed lung, the atelectatic portion, because it's getting pushed on. Same over here. If you have someone who's not in immediate distress, don't send them for thoracentesis. This is heart failure. They just need diuresis. If it were unilateral, then we're not quite sure what caused it. But when you see this, which we see all the time, and they're not in distress, relax, give them some Lasix. If it doesn't go away, then we can tap it. Here's an effusion that is somewhat loculated. That's a little bit more concerning, and you can appreciate, do you see the lighter gray around it? That's almost like an orange peel or a rind. So that's going to be really hard to re-expand once that fluid is drained. And here's an example of really bad loculated fluid on a CT scan. You don't want to stick a needle in that, it's not going to do anything. Here's a small pleural effusion right there, again, the area of the lung that's atelectatic. And then this is pericardial effusion. So this patient warrants an echo to get a better assessment, is it causing any functional impairment or not. Pulmonary edema, again, I want to just emphasize the ground glass nature, classic cardiogenic pulmonary edema. ARDS is a little more robust generally on CT scan. And ARDS as a clinical entity, we call it having baby lungs, and the whole reason you use lung protective ventilation is they've got normal lung right here. And if you end up putting them on normal mechanical ventilation, you're going to blow that normal lung out. This stuff isn't working well, but it's always that kind of mosaic pattern where there's some good next to some bad. It's bad zoning. IPF, here's an example of honeycombing. It literally looks like a honeycomb. And then you see these areas here, these airways that are dilated out to the periphery. That's what we call traction bronchiectasis. So the scarring in the lung tissue has created a situation that has tugged open and held open those airways. For COPD, two basic patterns that we regularly see. When you see paraseptal emphysema, it's up against the pleural edges. And then bad bullous emphysema. Someone who's got this much lung destruction, I can't help with those coils. There's not enough tissue to grab onto. Mediastinal pathology, and I've got about 5 more slides, so let me just crank through this. Again, if you're interested in mediastinal pathology, you've got to get a scan with contrast. That's going to be very important. And what we really are looking at oftentimes is whether or not a lymph node or collection of lymph nodes are going to be accessible to us doing bronchoscope with EBUS, where we put the ultrasound camera in there and do real-time biopsy. If the lymph node were sitting over here, I can't get to it without going through aorta. But when the lymph node is sitting right here against the airway, bang, that's perfect for me to go after. Here's an example, this cookie-like image of an aortic dissection. And then, again, I think we literally have 4 slides. VQ scan, I'm going to show you the ideal because the real images are really hard to pick up. Nuclear medicine docs spend their lives getting good at this. But the basic issue is when you've got a patient with chest x-ray, if they have a pleural effusion, you're probably going to see a matched defect in ventilation and perfusion because there's no lung there. When they have maybe a little bit of atelectasis, and then they have normal ventilation and jacked up perfusion with unmatched defects, that's PE. Normal looking x-ray and matched defects throughout, that's going to be some airway disease, some other COPD type process. Here's a PET scan, simply to emphasize You've got an abnormal finding on a CT scan, lights up like a Christmas tree. It's a metabolically active process. Probably malignant, but it could be infectious, could be other things. Tissue is certainly warranted. This is a vision of an ultrasound. And bottom line, when we're doing thoracentesis, this is the image we have to save, where we show fluid, lung, diaphragm. The needle's coming in from right there. So that's into the black space where we can drain that fluid. This is not a large effusion. And then this picture and this one demonstrate that GPS system I was talking about, the super dimension bronchoscopy. So again, there's a nodule out in the middle of nowhere, not something that would easily be obtainable normally, but when we marry it to this proprietary software, we can go down and we can hopefully get to that vicinity and then use other modalities like radiologist to prove that we're in an area that is not normal tissue.